Well, good morning, everybody, and welcome to our next session at the 2021 Medicare Advantage Summit. My name is Shawn Martin, and I'm the Executive Vice President and CEO of the American Academy of Family Physicians, and I will be your moderator this morning for an interesting discussion on the changing landscape of Medicare. To help us frame, we have a two-part discussion for you this morning to help us frame our thinking around the growth and changes in the landscape of Medicare. We are going to start our conversation this morning with Allison Reiser, who is a principal at ATI Advisory. Following Allison's presentation, we have an excellent panel of experts who will weigh in on their observations of the information shared by Allison, and then we will have a Q&A session. If you do have questions, please feel free to submit those, and we will pull a few of those to ask our distinguished panel this morning. So with that, as I said, we're going to start our conversation with a framing around the issues that we plan to discuss this morning. And it's my pleasure to introduce Allison Reiser. Allison.
Thank you, Shawn. And thank you to BMA and also to those who are here with us today to listen to this really interesting panel. I am super excited, so I promise I won't take too much time spending details on demographics. That's going to stand between you and this really interesting panel, but I do want to provide a foundation that I think will help the conversation. So just real quickly, a little bit about me and a little bit about ATI. ATI Advisory is a research services, advisory services consulting firm. We focus on frail older adults, and I lead our business area on dual eligibles as well as long-term care, and then some data efforts, including this particular one with the Better Medicare Alliance. And prior to joining ATI, I was with United Health Group for over a decade, most recently on the United Healthcare side, where I was leading efforts on dual eligible and DSNP policy. So I'm going to walk through some demographics, as Shawn mentioned, kind of level set for the conversation, including trends in the population generally, but then also the relationship in those changing demographics with respect to Medicare Advantage enrollment. You could advance to the next slide, please. So first, before I get into the Medicare Advantage aspects, just a quick snapshot on race and ethnicity among Medicare beneficiaries. You see two bar charts here. These are comparing new Medicare enrollment with total Medicare enrollment by race and ethnicity. And what you can see are some subtle differences between the charts, specifically that white Medicare beneficiaries represent a smaller portion of individuals newly enrolling in Medicare than they do for the whole Medicare population. So what does this mean? It means that the population is becoming more racially diverse. So there's a 3-point differential, which maybe feels small, but if you think about the size of the Medicare population at large, that's about 2 million individuals in the Medicare population. And if you compare this to 2013, so I don't have 2013 data on the slide, but if you compare this to 2013, 76% of the Medicare population was white. So this is a 6-point differential between 2013 and new enrollees in 2019. So you definitely see this trend in the Medicare population becoming more racially and ethnically diverse over time. I think over the past decade, we saw this shift toward more Hispanic beneficiaries and slightly more Black beneficiaries. And then more recently, I think what we're seeing is a shift toward more Asian and other beneficiaries. So those with specific racial and ethnic backgrounds that are not reflected necessarily in these aggregate categories on this slide. Next slide. Age is shifting too. So I do want to just point out that about 14 to 15% of the Medicare population is under the age of 65, meaning they are eligible due to disability or end-stage renal disease. This has decreased over the past 10 years by about a percentage point, but again, still a large number of Medicare beneficiaries under the age of 65, about 9 million individuals. But of course, we do have the baby boomer sort of phenomenon, and that population proportionally is shifting Medicare to being more heavily 65 to 84 years of age. So it's becoming older, not necessarily the oldest old, but we are definitely seeing this shift toward more 65 to 84-year-olds. Next slide. And then alongside this, enrollment in Medicare Advantage is increasing too. So we are currently at about 43% of Medicare beneficiaries enrolled in Medicare Advantage nationwide. I'll show what this looks like across the states in just a moment. But you can see here on this graphic that MA enrollment has grown considerably at the same time that we are seeing this demographic shift. And that's not coincidental necessarily. And depending on the projections that you follow, we have a couple here on this graph. but depending on the projections that you follow, Medicare Advantage enrollment may surpass 50% very soon. And there are already some cohorts that are nearing or above 50%. And I'll talk a little bit about some of those individuals here in just a few slides. Next slide. So by state, the majority of states have more than 40% of their Medicare population enrolled in Medicare Advantage. We do have a few holdouts for a variety of reasons. There are some state policies, for example, that make Medicare Advantage enrollment higher or lower. But year over year, the colors on this map have changed dramatically. So ATI has this map from last year as well. And we only had 13 states last year with 40% or more enrollment in Medicare Advantage. So 13 last year and 30 this year. Next slide. And so going back to the changing demographics then in the Medicare population, and also some elements that I didn't touch on with respect to clinical complexity and functional complexity, but I think may come up in the panel discussion, it makes sense then to see enrollment in special needs plans increasing as well. So in particular, DSNPs, dual eligible special needs plans, which serve low income dual eligibles who are disproportionately racial minority. Dramatic increase in the last few years in DSNP enrollment, but all three SNP types. These are the programs within Medicare Advantage that are serving the most complex beneficiaries, rightfully. And that's not to say that the remainder of the Medicare Advantage program isn't also serving complex or low income or racially diverse individuals, because it is, particularly sort of at the margins of the program, but definitely a growth in the changing demographics and enrollment in SNP year over year. Next slide. I talked about race and age. We also see this shift in income among Medicare beneficiaries. So these are data from a study that we've done 3 years running now with BMA, and particularly in Medicare Advantage. You see this increasing portion of low income beneficiaries. But also just generally, we know that Medicare Advantage enrolls a higher portion of low income beneficiaries than Medicare fee-for-service. So certainly a lot of this is going to be driven by those DSNP and ISNP numbers that I showed in the previous slide, but that's not accounting for all of it. Medicare Advantage offers cost protections that are attractive to low-income beneficiaries. And so what you see here is that more than half of enrollees in Medicare Advantage are below 200% of the federal poverty level. So what we would refer to as low income, meaning they're earning less than $24,000 a year, more than half. Next slide. And so this then translates into a higher portion of dual eligibles in Medicare Advantage. So you see it starting to tick down year over year in fee-for-service over this study period, and then sort of ticking up a little bit year over year in Medicare Advantage. There's a small typo, I apologize, on the right side of the slide. It should be 2018, but we had 22% of Medicare Advantage enrollees in 2018 who were duly eligible for Medicaid, compared with 15% in fee-for-service. So that's a 7-point differential, roughly 50% more likely in Medicare Advantage to be duly eligible for Medicaid. Next slide. And then similarly for race and ethnicity. So this graphic's a little different than the last few. This is showing you what portion of each population is in Medicare Advantage in 2017 and 2018. If you focus on the bars in the middle, for example, what that is saying is that in 2017, 41.7% of Black Medicare beneficiaries chose Medicare Advantage. And by 2018, this had grown to nearly 49% of Black Medicare beneficiaries. And you can see that generally Black and Latinx Medicare beneficiaries are enrolling in Medicare Advantage at rates that are considerably higher than white Medicare beneficiaries. And this is intricately intertwined with income and dual status. And again, for these two cohorts, Black and Latinx beneficiaries, we have now gotten to a point where half of the population is in Medicare Advantage. Next slide. So where are we now? A couple more slides, and then I promise we will turn to the panel. So these get at the interaction that I was just discussing, right? The race and income and dual status interaction. So these data points are 2018. It's the most currently available at the time that we completed this study. You can see here that regardless of fee-for-service or Medicare Advantage enrollment, Black and Latinx Medicare beneficiaries are considerably more likely to be low income compared to white Medicare beneficiaries. These are pretty stark differences. But then even within the Black Medicare population, and even within the Latinx Medicare population, you see a higher portion of lower income beneficiaries enrolling in Medicare Advantage. So there's a lot to unpack on this slide, but more than 3/4 of Black beneficiaries, 77%, who are enrolled in Medicare Advantage, and 80% of Latinx who are enrolled in Medicare Advantage are low income. So I'm going to pause for just a minute because, again, there is a lot packed into this slide, but I do want to draw your focus and your attention to these red numbers on the slide because these statistics are really startling and very important to discuss if we want to genuinely talk about equity. And then finally, if you could go to the next slide, similar cross tab here, but this is focused on dual eligibility. So these numbers are showing what portion of each cohort is dually eligible for Medicaid. Again, drawing your attention here to a couple of stark differences. One is that the comparison of Black and Latinx Medicare beneficiaries with white Medicare beneficiaries. Regardless of fee-for-service or Medicare Advantage enrollment, Black and Latinx beneficiaries are way more likely to be dual eligible. But then drilling down even further, those enrolled in Medicare Advantage are more likely to be dual eligible than their counterparts in fee-for-service. So for example, if you look at the bars on the right, the Latinx population, those enrolled in Medicare Advantage are 8 percentage points or 20% more likely than those in fee-for-service to be dual eligible. Next slide. So that was a lot of data. I do think it's important to set the foundation. Hopefully everyone's head isn't spinning right now with all the data, but I do think it's important to set the foundation for the conversation that you all are about to have. So with that, please feel free to reach out with any questions, but I'm going to turn the panel, Shawn, back to you.
Great, Allison. Thank you so much for that excellent overview, excellent framing to kick us off with our panel. So this morning, I have the honor to introduce a very distinguished panel. First, I would like to introduce Dr. Phil Oravetz, the Chief Population Health Officer at Ochsner Health in Louisiana, New Orleans. Next, Mr. Dennis Borel, who is the Executive Director of the Coalition of Texans with Disabilities. And finally, Dr. Elena Rios, who is the President and CEO of the National Hispanic Medical Association. I'm going to ask each of them to give a little bit more richer introduction of themselves and their organization as they kick off their comments and responses to the conversation we're going to have this morning. And Dr. Rios, I would like to turn the program over to you to get us started this morning.
Oh, great. Well, thank you to BMA for organizing this great panel, and thank you, Shawn, for moderating. I think what this data shows is nothing new. It's really been an evolution of changes of diversity within different aspects of our elderly generations. And I think what's important is that now more than ever, and I think with the COVID-19 pandemic, we have seen the realization of the importance of having data collection by race and ethnicity, by having more data collection by the targeted healthcare variables that are important to reaching these populations. And I think my greatest concern here is that we don't lose sight of the heterogeneity of the Latino population. We talk about Latinx, Latino. We talk about Latinos as if they're one group, and there's so many differences, especially those that are undocumented, that we now know immigration reform really needs more policy muscle in Washington. But undocumented, US-Mexico border, even though they're not just Mexican anymore, all the Latin American country people coming in. And then the Puerto Ricans and Cubans that are citizens, the they're just different groups, but we still know that over 60, 63, 64% are Mexican American, mainly in the Southwest. But even they are moving into the Northeast and the South because of jobs. So there's so many differences among our population that if we're going to care for them as they are increasingly part of the Medicare Advantage, there really needs to be more culturally competent programs, not just language, and they all have their own different, I'm going to say, specific words that they use for healthcare issues, but there's a whole lot of cultural issues, and I think the culturally competent and linguistically appropriate services standards that were brought up by the Office of Minority Health way back when are still very appropriate for this discussion. And I also think the dual eligibles and the whole concept of finding ways to improve their care with a better healthcare workforce, not only doctors and nurses, but I think community health workers and those who can help navigate people within our systems of care is going to be even more important as we find more poor people and more, people with less health literacy, people with more chronic problems. There's just so many things to take away from this data. I think it's just so rich in policy aspects for the near future. And I know we've been looking at this for a while with Medicare Advantage growing so fast. And I think that it's an important time for better Medicare Alliance and for Medicare Advantage.
Great, thank you for those comments. Dennis, let me turn to you next for your reflections.
Thank you, Shawn. I'm Dennis Borrell. I'm the Executive Director of the Coalition of Texans with Disabilities. And our organization was actually founded in 1978, well before the Americans with Disabilities Act. And I always like to point out, few people want to recognize this, but the ADA was a Texas invention. It was signed by George Bush, President George Bush the Elder, a Texas president. And the main advocate was Texas businessman Justin Dart. So we take a little credit for that. So yeah, we are a cross-disability advocacy organization. Real brief, when I say cross-disability, I mean cradle to grave, all kinds of disabilities. And we're linked with many organizations that many of you are familiar with that may deal with a single chronic illness or disability, like the Epilepsy Foundation, the MS Society, the Paralyzed Veterans, the Council of Bond. All these folks are part of our links, and we kind of represent them all, mostly in the Texas Capitol, but also on the federal level. And okay, you're saying already, what's this disability guy doing here? Well, that's why I want to specifically thank the Better Medicare Alliance for having me as part of this panel. We're, a very distinguished panel here. As Allison mentioned, there's over 9 million adults with disabilities under the age of 65 in Medicare today. That is a very, very significant amount. Those are people that are at our heart. And think also, of course, the older adults. I think everyone understands that the incidence of disability is much higher as we age. So yes, disability advocates are shoulder to shoulder with those advocates for senior citizens and older adults. I also wanted to mention that you hear a lot of the phrase social determinants of health. Certainly applies with what Dr. Rios was saying about the Latinx population and other minority groups, rural versus urban, where you live, what community you live in. But to me, I've always felt that lived experience with disability is part of the social determinants of health, and really is a tremendous, can be a tremendous barrier to access. So, why do people with disabilities like to choose Medicare Advantage? And by the way, there are more people, beneficiaries with disabilities in Medicare Advantage than there are in fee-for-service. That tells you that they're making the choice to go there. Certainly the prescription drugs, care coordination. If you have a disability, it's definitely harder to communicate with people, especially if you have a speech impairment, especially if you don't see very well or hear very well. Care coordination is a massive benefit. Think about home modifications only available in Medicare Advantage. Now, that doesn't mean you can renovate your kitchen with Medicare Advantage dollars, but what it might mean is you might be able to lower that counter in your kitchen so that you can actually reach the stuff so you can cook your own meal. That is a home modification. We tend to think of things like bars in the restroom, which are tremendously valuable as well, only available home delivered meals as well. Telehealth, Medicare Advantage has been a pioneer in spreading telehealth. extremely important for rural people and people who are mobility impaired or may not have their own vehicle. You may not know this, but people with disabilities are the least likely demographic group to own their own vehicle. Not a surprise when you think about it, but often we don't. So there are some changes coming, and I'm going to be cognizant of where I am here. Okay, I'm in pretty good shape time-wise. Okay, so a few things that we're kind of keeping our eye on in the changing landscape of Medicare and Medicare Advantage. For one thing, there's a lot of talk about dental, hearing, vision, all important benefits, all that we like. We have to be very careful as we talk about installing those into the larger Medicare fee-for-service program, because they're essentially widely available already in Medicare Advantage, and there needs to be some very, you don't want to have an unintended consequence. You end up making it more difficult to get your eyeglasses because you're in Medicare Advantage and if we're in Medicare fee-for-service. Apparently, this is a real possible unintended consequence. Got to watch that. Another emerging topic we're hearing a lot about is the quality adjusted life years. And I had to actually read that. Everybody calls it the QALY. This is the biggest load of discriminatory rubbish I've seen in a long time. What it does is it actually estimates what your value is and whether the healthcare expenditures that you might need are worth spending on you because your life isn't so valuable. That's essentially what it is. This is not a concept. It's already in practice in many parts of the world, including Europe, where we often look to as innovations. Now, that is, here's an amazing statement that came from the National Council on Disabilities about that. And the National Council on Disability, by the way, is a federal agency that oversees a lot of federal policy and offers technical assistance. And here's what they said: the QALY, it's used in the U.S. would result in rationing care to seniors and people with disabilities. Using a formula that discriminates against any one group, not to mention many groups that include the most vulnerable among us, is more than concerning. It's a non-starter. So pay attention to this QALY concept. It's also sometimes called the ICER concept, after another group that's pushing this idea that we should decide where, who's worthy of getting health care. Now, there's a link to that too. And that link is involved with what I call foreign reference price indexing. And what that means is where we're not going to have essentially a Medicare type formulary for prescription drugs. We're going to go to a more preferred drug list, which is what happens in Medicaid. And we're going to base what we pay for drugs on what other countries pay for drugs. This is a politically popular statement. Pay attention to this. This can be very dangerous when it comes to access to medicine. Let me give you a few facts on this. New medications in the United States are available to 87% of people within 0 to 3 months. That's pretty damn phenomenal and very important in the pandemic times we're living in. Well, I have a list of several countries here. What might be a good country for access to medicine? Let's take the United Kingdom. Well, as I said, the United States, 87% access to new medicines. United Kingdom, 59%. United States, access to new medicine, 0 to 3 months. United Kingdom, 18 months. Wow. They have. Do we really want to emulate that? Well, let's take another one. Let's take our neighbors to the north, Canada. Love Canada. I grew up in a border city to Canada. It's a wonderful, wonderful country. Only 46% of patients in Canada have access to new medicine, and it takes 15 months. It's pretty concerning, isn't it? Especially if you have a condition that would respond well to new medicines. And of course, there is a European country that's kind of held up, and I got to tell you this one, but it is a bit of an outlier. Greece, often the cradle of civilization. Only 16% of people in Greece have access to new medicines, and it takes 31 months. If you are an older adult in Medicare and we go to this, maybe you don't have 31 months to wait. Do we want to go to this foreign price indexing? I think not. And I'll tell you another thing is I don't think that that's a very good way to save money. I think a good way to control costs in any public health program is to keep public health beneficiaries as healthy as possible. Seems like a shocking idea, isn't it? But if you keep them healthy in their homes, not in the emergency room, not in the hospitals, not in unnecessary institutionalization in nursing homes, you know what? You spend less money. And that's where people want to be. And also, again, this hospitals and emergency rooms are maybe not the greatest of places to be if you're not the healthiest person, and there's a bunch of COVID patients in there too. So I'm not a believer that all these things like qualities and foreign price indexes are the way to go, but we need to keep that changing thing in mind as well. One thing I do like, I would like to see happen, there's a pending bill in Congress, HR 1946, the Multi-Cancer Early Detection Screening Coverage Act. These are things that are coming along lines of blood tests that will test for multiple cancers easily. Right now, it's in the FDA process, expected to be approved soon. It's expected that it would take a decade after FDA approval before such early detection technologies would be available in Medicare. Well, again, how many people in Medicare don't have 10 years to wait? And if you can get early detection of any kind of cancer, you're much better off. So we strongly support HR 1946. So we see Medicare as being very important to older adults, very important to people with disabilities, regardless of age or in there. And we think it, of course, can be tweaked and made better. And we like Medicare Advantage, as I said earlier. People with disabilities are more represented in Medicare Advantage and fee-for-service. Another factor that is there is that many of those plans cost nothing. I said earlier that people with disabilities are the least likely group to own their own car. They're also the lowest income demographic group in our society. Again, that's not a surprise when you think about it, but sometimes we don't. And they're also more likely to die prematurely, but not from their disability or their chronic illness, from substandard healthcare or lack of access to the healthcare they need. So I am really, really honored to be here with people of great talent, great skill, and great depth of knowledge in this. And what I would say is, going forward, as we continue to advocate with the physicians and the other groups here, and let's all work together, and let's have these disability advocacy groups continue to work shoulder to shoulder with you guys and get smart policy, and let's make Medicare Advantage even better than it is. Thanks, Shawn.
Thank you, Dennis, so much for those comments. Really appreciate that. Dr. Oravetz, let's turn to you for your comments, and then we'll jump into our Q&A session. So Phil, please.
Okay, great. Thanks, Shawn. And thanks for having me, Shawn. And thanks, BMA, for the invite today. It's always a pleasure to represent Ochsner Health in federal policy and discussion. And Shawn, just by way of introduction, I am a family doc. So nice to see our academy being represented at the national level. It always makes me feel good after paying dues for all those decades. So a little bit about me. Ochsner Health is a large integrated delivery system. We're based in New Orleans, but we really cover the entire state of Louisiana and the Mississippi Gulf Coast. And we really manage about a quarter of the state's population. So we have over 1 million patients of the 4 million residents of our state who are in Louisiana. I think what makes Ochsner really unique is very rapidly adopting a value-based pro forma, whether it's employer-based contracts, insurance-based contracts, or even self-insured of our own employees. And we currently have 3 Medicare Advantage contracts that we manage. All of those carry downside risk. And by way of disclosure, Ochsner had its own health plan for decades and hasn't had it in the last, 15, 16 years. And on January 1st of 2022 is getting back into the Medicare Advantage business. So we're going to be a provider-sponsored health plan starting the first of the year, and our open enrollment is underway. For me personally, hard to believe, next month I'm coming up on my 10-year anniversary at Ochsner, but spent my whole career on the West Coast really managing Medicare Advantage risk contracts. And on the delivery side, so that's the first thing. But we'll talk, and I know in the Q&A we're going to get into Medicare Advantage. Why is it growing so fast? And Allison, I agree with you. I believe Medicare Advantage very quickly is going to be over 50% of all Medicare enrollees. But I would say, and really appreciate Dr. Rios's comments, because what's really happened in the last several years is we've known about disparity, right? This is nothing new for those of us who, have been on the provider side and in the trenches taking care of patients. But what's really focused and shined a big light on this is the COVID pandemic. And Ochsner's published on this. It's very clear, right, that racial and ethnic disparities have played much more prevalent in communities of color, and no place better has demonstrated that than New Orleans and Louisiana, right, in this part of the country. So we have been seeing it and publishing on it and researching it. And the important thing I think we'll get into is, so what are you going to do about it? And this is where, we're really exciting about the work that's happening at Ochsner and around our state. So let me just give you a few data points here. The first thing, I absolutely agree 100% with Dennis. What Medicare Advantage offers in an integrated delivery system is care coordination. Care coordination that you just don't have in traditional fee-for-service Medicare. We have a single instance of our electronic health record that goes across the entire region and state. So you can go anywhere, and if you're getting your care in the Ochsner system, we will know about you, right? We'll be able to know what meds you're on, what studies you've had. That makes the care much more efficient, much more affordable, much higher quality. And we've been able to document all of those quality improvements. So it's care coordination. The second piece, and it goes back to our health record, starting about 3 years ago now, hard to believe, for the first time, we started collecting social determinants data within our electronic health record. So we now have all of that data available. And again, absolutely agree with Dr. Rios. We are now actively collecting on every patient who checks in, making sure that we have accurate information on race and ethnicity. We at the provider level just historically haven't been as diligent collecting that information as we need to. If we're ever going to get ahead of this, we need a much more robust data set. I'm glad to tell you that our system is doing that now, and I think all major health systems around the country are doing this now. We are gathering a massive data set that is really able to give us the data that we need. And in point of fact, we report our quality scores now by race and ethnicity. We report our patient experience scores by race and ethnicity. So we're able to slice and dice our data to be able to see the pockets of opportunity that we need to improve. So that's first, just in terms of data collection. The second is we are now working with other payers, and actually even with the state, and we have stood up a community resource platform that is now statewide, right? There are 3 or 4 national players in this space. And so from our electronic health record, we're able to refer patients to community resources. So we can identify pockets of opportunity and start referring patients into community programs. Now, what makes it a lot nicer is, and Dennis really hit on this across many areas, right? Medicare Advantage plans are now collecting, they're now intensely interested in this social determinant data. And we're working with our payers and even with ourselves to, understand what that data is telling us. And in Medicare Advantage, they have the resources to be able to provide transportation, post-discharge meal benefits, DME equipment that Dennis talked about. These are just, and really it gets as simple as, vision and dental and gym memberships, right? It turns out our gym membership actually is probably more effective in preventing loneliness as opposed to even exercise, right? As a social determinant. I will tell you, Medicare Advantage plans are at the forefront. And what's really exciting for me as a family doc who does this work across populations, we're finally at the inflection point. I think, it's something Dr. Rios and I will probably agree with. As I talked about, we've known about this. We're finally at the inflection point in medicine that we recognize that social care, right? Social care is not only equally as important as medical care. It's probably more important than medical care. And, more healthcare doesn't mean more health, right? That's the other thing we're recognizing, that social care probably has more impact on patients and communities as opposed to medical care. And Medicare Advantage plans are at the forefront of that, right? Allison, when I get energized with your data, that's only going to continue. And in fact, that's accelerating right now because each of our communities have unique challenges and opportunities, and so we're going to be able to custom tailor our interventions to those communities. And we're doing this at Ochsner Health, right, throughout the state. And we're not alone. Health systems all over the country are embracing this. They're embracing this, the move to collect and report and act upon social determinants of health, right? I do say final comment I'll have, Shawn, and then I know we have a lot to talk about in our Q&A. I will tell you at Ochsner, the fastest growing job description, and we're the largest private employer in the state. We're over 30,000 employees. The fastest growing job title at Ochsner is a community health worker, which I think is a very telling statistic for just what's happening here. And so I think what we're going to talk about, I think in the Q&A is, okay, what are the plans doing to fuel growth? What are the systems doing to fuel growth? But I think there's a recognition that if we're ever going to improve the health of our communities, that Medicare Advantage is on the forefront of that, and I think it's going to continue to be way ahead of traditional Medicare. And in my mind, as we start talking about, so why do patients like it? We'll go on and on and on about what is it about MA plans that are recognizing? We on the delivery side recognize this, and as I say, we're at this inflection point, which is just a beautiful thing in my career. So with that, I'll leave other comments till the Q&A.
Great. Well, thank you so much. Thanks to each of you for your comments and for the good conversation that we started this morning. So we're going to move into some moderated or facilitated questions. And Phil, I'm going to come right back to you, but Dennis and Dr. Rios, please jump in afterwards. I'll take turns on each of these questions. But in Allison's presentation on slide 4, she showed in a very visual and explicit way the growth in Medicare Advantage over time. And I'm curious from your perspective, starting with you, Phil, what is driving this growth in Medicare Advantage enrollment across all populations and all geographies? What are 2 or 3 things that you think are really behind this growth in enrollment?
Yeah, and it's thank you, Shawn. And it's interesting that I'm going to turn my angle a little bit on this and think of patients as consumers of healthcare. And one of the things that's really fascinating, which is hard to do as a physician, but as I think of patients as consumers, and I will tell you, New Orleans is a very heavily penetrated Medicare Advantage market. Open enrollment just started last Friday. It's amazing that there is an incredibly competitive marketplace for Medicare Advantage enrollment. Again, you don't see that in traditional fee-for-service Medicare, and how that's playing out in and I'll just use New Orleans as an example. We talked about the benefits. The benefit designs change on an annual basis. And it's, we heard a little bit about, vision and dental and now most of the plans have 0 premiums, right? And so that's been a big differentiator over the last several years. Plans, plans are at a race to be competitive in the marketplace. And so I really look at a competitive marketplace. Dennis, you did talk about drugs. What I do like about another issue of Medicare Advantage is that there are integrated pharmacy services. When I say integrated, we're integrated. Like pharmacy services and real-time pharmacy benefits are integrated right into our system as well. But I would just say, I think it's there's a competitive marketplace out there. And that, and whether it's in healthcare or anything else, that benefits consumers. And so, our own, as I say, our own plan is now in the marketing game. It's competitive, and I think patients are going to shop their needs, right, and have and choose health plans that best meet their needs. And I think Medicare Advantage plans are continuing to add benefits and recognize where the opportunities are to just to attract more consumers, but for us more patients. So I would just say I think competitive marketplace. I think patients like the benefits. They like having all this integrated care, and particularly as we get into the dual eligibles, and Allison, as you talked about, expense and cost is totally an issue. It's one of the issues, right? And so what I like is, patients can have choice of 3 or 4 plans, and that's growing across every state now. I think, Allison, I was really amazed when you said how many states have a pretty big penetration of Medicare Advantage now. That is just great for consumers of healthcare, because they're going to be able to let the marketplace determine which plans are going to be winners and which are losers. So maybe that's where I'll start. I'll stop there and hear from others.
That sounds great. Dennis or Dr. Rios, any comments on this question? Dennis, go ahead.
I got to say, Phil hit the nail on the head. This is more about consumer economics than it is about healthcare, really. And you're right. It could have been, which kind of car you're going to buy, as well as healthcare. It's just it is. Let's face it. People. Most of the people are older, and there is, of course, the younger people with disabilities. Younger people with disabilities are going to be lacking resources. Older people have been around long enough to become pretty good consumers. In fact, they're probably the best consumer economics people in our society. They know where to find the best deals, and they know where they want to go with it. And this is something of incredible value to them, more so than that car, frankly. So I really see this as more an economics answer than a healthcare answer.
I also just want to add that the coordination of care, I think, is the selling point, because it's so hard to have to go from one place to another, to get your labs, to get your doctor's appointments, to get your specialty doctor appointments.
Yeah.
And I think that Medicare Advantage really was ahead of its time when it realized that this was the kind of way, the way to go. Before Part D, it included medications, I don't know if you call it quality care, but I would say now we'd look back and say there was really a focus on the importance of quality and patient satisfaction right from the beginning. And I think that's been a big part of the selling point. And the other thing is, there's really been a lot of marketing about the importance of this, new kind of healthcare for Medicare in terms of having everybody connected. All your needs connected. So I think that's another important part of the story of Medicare Advantage, was the immense marketing, especially to our communities of color and low-income people.
Well, great. So continue on the growth pattern. Dr. Rios, let me start with you on this question. Allison noted, significant is how I would characterize it, growth in populations of people of color in Medicare Advantage over the past few years. So when you think about this growth and kind of the diversity in MA enrollment, what are some of the drivers you see? And of course, there's always room for improvement. So what are some things that you think should be done to continue on this trend or trajectory to better serve these populations?
I think, for Hispanic and African American, I think they're very loyal to their, when they select a program and I think that the loyalty is what needs to be focused on, the importance of coming back to consumers that are in the systems to let them know about increased advantages, increased benefits, the social determinants that was mentioned, the issue of transportation and meals and gym membership. You know, it could be very new to somebody who's been on Medicare Advantage for a long time and they don't even know about it. And I think that you have to go back to the same people that have been a part of your system, because word of mouth is really strong in our communities, and that's how more people will become aware of the immensely important, approach that Medicare Advantage has. And I also think the health systems that get engaged, like you mentioned, Phil, you have 3 different Medicare Advantage plans. Well, you know, it's up to the consumer to decide which one, but I think as a whole, Medicare Advantage has lots of new things and things coming up in the future that will help to drive keep the loyalty of the African American and Hispanic and others, low income people, et cetera, that are already involved, and their families and their communities will then follow suit.
Great. Phil or Dennis, any comments on this topic?
Go ahead, Phil.
Yeah, and I would say one of the things, again, interesting, I think, one of the real accelerators here, I keep coming back to, has been COVID. Our system our systems had a long history of providing telehealth services, historically hospital to hospital, whether it's in psychiatry or stroke care. But, under the COVID pandemic, it's now, this is now a routine part of our care process. And, I would describe, I think it's a huge game changer in terms of improving access to care. And to be honest, what we're seeing in our system, and again, I think we're very representative of of a national trend in the behavioral health arena. I would dare say 80% of all visits are now virtual. Right. And so, Dennis, to your point, do you need a card? No, you need the future world of healthcare is you need a tablet or a smartphone. And, the good news is that technology, is pretty pervasive now, right? Just about everyone has a smartphone of some ilk. And so, you know what? You now have access to behavioral health services. What's fascinating is, when you solve one problem, you realize you have more problems to solve. And, example in Louisiana, and again, I don't think we're unique in this, is we need broadband everywhere. Right. And I know that's part of the proposal on the infrastructure package is, we live in a world where if you're going to have kids go to school or people get healthcare that have access issues, to me, the biggest solver of access is telehealth. And I think that is now, we've now hit the threshold where we realize this is going to be a big part of how the future care delivery system is going to operate. And again, it improves access, And you know what? And you can have care everywhere. Where I know we've talked more about race and ethnicity today, but geographically, geography is an equal barrier, right? If you live in a rural community, you have equal challenges, right, of inequity in accessing care. So I think that's just telehealth has just been a game changer. That wasn't really here 3 or 4 years ago in the way that it is today. And, we're really advocating to, keep that ball rolling. This is again, another game changer. And I think Medicare Advantage plans are on the forefront of that, right? How do we use these technologies to better patient care, get patient care to the next level?
Dennis?
Well, I have to say that for some time now, several decades, there's been a flip in the change in the way America deals with its citizens with disabilities and providing health care. And what I'm talking, and this is directly impacting Medicare Advantage and Medicare as a whole. In the past, it was very, very common to institutionalize people with disabilities, often at birth or very shortly after birth. We're talking about people with Down syndrome, cerebral palsy. People with cerebral palsy, they may have no intellectual disability, would still be institutionalized from near birth. We had a system of state-run and private run institutions. We had nursing homes that, believe it or not, used to have far more people going through them. So what we've seen is a societal shift in how we care for people, how we care for older adults and people with disabilities. And you know what that is based on? Respect. Respect for where they want to be and what they want to do. Phil, you hit the nail on the head. There's the medical model and there's the social model. The medical model treats people as a diagnosis. The social model looks at the whole person and follows what they want to be. So we know that the people want to be in the community. Now, if they're going to be in the community, they need those services and supports to survive in the community and have an independent life. And you know what? That's cheaper than institutionalization, by the way, a lot cheaper. And so that is driving a change toward, and this has been emerging for many decades, but it's not done going. It's still moving along the pathway. I'm going to just tell one little story about telehealth that I think, I don't want to repeat everything that's been said so far, but I worked on a teledentistry bill here in Texas, which passed. And of course, Texas is this massive state. And yes, I made the argument that transportation, especially for people with disabilities and rural areas and distance, all that good. And you know what else is good for? If you are that dentist, and I guess this would apply if you were a physician, and your first meeting is with someone on telehealth, you may determine that they need to come to the clinic. But you know what else you'll know? You'll know what accommodations you need to make so their visit is successful. You'll know that, I better have an associate come and be available to help me transfer this individual from their wheelchair into the dental chair. Or maybe I can figure out a way that person stays in the. That is amazingly valuable. You don't want to lay eyes on a person for the first time when they're in your clinic. If you can lay eyes on them and have a conversation, know more about them, know more information, and just get a sense of, okay, I need to, things you would not have picked up without seeing them on a screen is immensely valuable to the effective delivery of healthcare.
Thank you for that, Dennis. Dennis, let me stick with you.
Sure.
In your comments, you noted that a large number of individuals with disabilities are enrolled in Medicare Advantage plans. And in Allison's presentation, she talked about the increasing number of special needs plan enrollments under Medicare Advantage. So let's think about, kind of at the state level. You're a state advocate. You advocate very effectively in the state capital. So when you think about alignment, like MA alignment across special needs plans, dual eligibles, how are they aligning with Medicaid? How could that be better? What are some opportunities you see here for the two programs to better serve their mutual beneficiaries?
Yeah, it's an excellent question. It's a growing piece, a growing preference of the disability community, and certainly older adults with disabilities. Very important. The one I found is particularly true of the dual eligibles. Okay, so you're getting your long-term services in Medicaid, and you're getting the other stuff maybe in a Medicare Advantage program. Well, the most easy thing to do would be to align the managed care organization so it's the same managed care organization delivering both. And that's what we often don't see. So you're over here, maybe you're dealing with Humana or something in the Advantage program, and United Healthcare and your Medicaid program here. So, we've done some pilots on that. We know that that's effective. So I think that kind of alignment of Medicare and Medicaid is important. And just coordination, to me, these are such different animals. Medicaid, state by state different, and state by state money in the pot going in there, and Medicare does not. And so we have this constant discussion. Will this work? And if it works, will it run into a barrier here or there? So I think we need to have some structures in place with the sole goal of trying to smooth out whatever differences there are, or create some forums where we can rapidly come to decisions rather than say, well, no, we're going to kick it up to CMS and they'll have them talk about it for 6 months. And because Texas is different than Louisiana, which is different than Utah, which is different than Hawaii. So I would recommend those things, more administrative streamlining than anything else.
So Drs. Oravetz or Rios, any alignments, the opportunities you guys see?
Well, first thing I'd say, yes, I think there is certainly, particularly when you talk about dual eligibles, you've heard us say, wow, care coordination is the sine qua non of really high quality care. And, and that means insurance coordination too. And there's certainly, I would say, going forward, opportunities to better coordinate from an insurance perspective, a Medicare and Medicaid, right? And as Dennis said, every state has unique flavors of, what the rules of the road are. But I think overall there's an opportunity to do better, right? This is insurance reform. We're doing this on the delivery system side, and I think being very successful by, as you heard, one is incorporating social determinants, and that's really is our mantra for providing high value, high quality care to our patients. I think insurance needs to get on that bus too.
Dr. Rios?
Muted. I was just from the racial ethnic minority perspective, which is something that we've seen as, again, is important for data collection. It's also important for the connection between Medicaid and Medicare. And Medicaid in states like California, New York, New Jersey, maybe, I'm not sure about every state, but I mean, the states with the large Hispanic populations or states with large Black populations are probably doing a little bit more for those populations from the Medicaid side because of the state options to do more optional, things that we would think would be optional. And I'll just give you one example. California just passed their law, Health for All, to have Medicaid cover immigrants that are undocumented over 50 years old. And I think that's incredibly game changer there in California, where 40% of the population is Hispanic. Not that they're all, most Hispanics have some family member that had some connection to being an immigrant in more recent times than, the white European immigrant that came way back when in the 1800s or 1700s. So there's a lot more, looking towards the future, thinking about how states like that can have, look at the connection between Medicaid and Medicare from the state. I think it's good.
Great. Thank you all for that. Just a quick time check. We have about 10 or 11 minutes. I have about 3 questions left for this distinguished panel.
Okay.
So we're going to move into a little bit more of a rapid fire type of approach here. But
Okay.
I want to start, Phil, let me come back to you. I want to start with, you guys have all spoken about the innovation of Medicare Advantage and how it's kind of driving innovations in care delivery. So, and you all have mentioned care coordination. So I'm going to challenge you not to say care coordination as the answer to this next question. But beyond care coordination, what are some ways that Medicare Advantage is really altering the delivery of care or the approach to care delivery that you think is beneficial and you would promote?
Yeah. So too, you've heard me, we kind of beat to death on our panel today, screening and addressing social determinants, right? That to me is just not happening in traditional fee-for-service Medicare. So I think Medicare Advantage really excels there. The other piece that I would say, and we haven't touched on too much, but I maybe just lob it out there at this point, care is moving to the home, right? We talked about access points through telehealth. Care is moving to the home. So, things that we used to require patients to come to the hospital or emergency room or even office, that's the next revolution. And I believe Medicare Advantage plans are on the forefront of that as well. So I think, addressing social determinants, and I believe moving care to the home probably are the 2 biggest innovations coming. And I think MA is at the forefront of both of those.
Okay. Dr. Rios?
I think I would just add the importance that was mentioned earlier about behavioral health. We've seen isolation with elderly, and let me just say, there's probably more interest in getting help when you're part of an MA plan, where you can, think about different types of things that you need: vision, dental, et cetera, and should start we should also start thinking about the opportunity for maybe, I'm going to say, group meetings, or, not feeling isolated. And that's a lot of what the depression of elderly stems from. The thing, I guess, would be counseling services, social work services that are part of, we think in terms of hospice for patients that are terminally ill. But I think before hospice, we even need the social workers to talk to family members about the care of the elderly and the important, to know all of the different types of advantages of Medicare opportunities.
Yeah,
So
what a great
we don't
comment.
do that.
Yeah, what a great comment. Dennis?
Number one, consumer choice is always a good thing and will force innovation right there. Number two, Medicare seems to be leading the way, Medicare Advantage in particular, in functional need, assessment by functional need, not by diagnosis, not by age of onset of any condition, which is what Medicaid does, which is a huge flaw in Medicaid. Medicare Advantage can lead the way where we need to go with true functional needs assessment, driving healthcare decisions, not whether you broke your neck at 28 versus breaking your neck at 17. Okay, that's it.
Okay, thank you so much. So a little bit of a wild card draw here. I want to go back to something that Allison, kind of pointed out, and she really kind of leaned into this in her presentation, and that's the recognition that disparities continue to exist in our healthcare system and even in the Medicare population. So again, Dr. Rios, let me come back to you. What are some specific things that Medicare Advantage needs to do to be a leader in kind of reducing disparities in our communities? And we talked about this a little bit earlier, but probably more from a policy perspective this time around.
I think from a policy perspective, Medicare Advantage needs to be part of medical education. The concepts of not just coordinated care, but racial, ethnic care at the elderly stage. We hear about nutrition, for example. Well, what about nutrition for elderly? And the other thing is how to connect medical education with public health, because that's a lot of what's happening with Medicare Advantage. There really is a new trend here. And I think it does happen to be with COVID-19 pandemic, realizing that you just can't put a mega site and have people that don't have cars get there, right, to get the vaccine. So
Yeah.
That's what's happening with Medicare Advantage.
Okay, Dennis?
Well, this may be longer than 2 or 3 years, but I would love to see long-term services and supports move into Medicare Advantage and Medicare as a whole. Right now, it's only short-term, and we rely on Medicaid, hence the dual eligible. Medicaid is terribly underfunded. Both Phil and Elena said, yeah, those community healthcare workers, though that includes people who come to the home of older adults and individuals with disabilities, help them with activities of daily living, and they are the poorest compensated jobs in our state. They're paid far less than working at fast foods, warehouse, entry-level work, and so consequently, that workforce is collapsing. If that collapses, then people will end up getting sicker, going into hospitals, nursing homes, et cetera. So I think the solution is let's move long-term services and supports into a new benefit under Medicare Advantage. Figure out how to do it. Pay those workers market wages instead of some legislatively set underpaid situation which collapses the workforce, and keep people healthy in their homes and ultimately have a sustainable public health system. That's it.
Awesome. Love that. Thank you. Phil, how about you?
Yeah, and I would say, I mentioned earlier that we now have a community resource network, right, set up across the state. Ochsner Health, and along with several of our MA plans, were part of that seed money to put into that. So I would say, a lot of the work that's happening on a social determinants perspective is coming from grants from our MA plans, right? They are coming into communities of color and ethnicity, and standing up resources and programs, right, to start addressing this, because they know down the line, some of these patients are going to be their MA patients. Some will be other MA plans, but the rising tide is going to lift all boats. So I think MA plans are invested in community health in new and important ways.
Great. So thank you. So my last question before we close is this, and I'm going to invite Allison to come back in for this final question for her perspectives as well. But you have the Better Medicare Alliance has afforded us an audience with CMS and medical directors and maybe some CEOs of Medicare Advantage plans. So I'm going to ask you in very explicit terms, what are the 2 or 3 things that you would ask them to do to improve their products? So Dennis, let me start with you.
Again, I'm going to go back to that long-term, start moving in the direction of taking long-term services and supports into the federal program, stop leaving it a state-by-state mix and match things, which leaves people out there on their own and ultimately losing the ability to stay in their own community at a lower cost than the alternative, which is hospitals and nursing homes.
Great. Phil?
Yeah, I really would echo that. As I talked about, it's social determinants, it's home-based care, right? Care is moving to the home. That's the next big innovation that's coming down the line, and up to and including hospital care, right? I mean, we're going to be able to do that. It really is recognizing that people do best when they're in their own environment.
Great, thank you. Alana, Dr. Rios?
Yeah, I would just say, and I'll just go to the diversity aspect here. I think we need diversity with CMS and with not just CMS itself, but the advisory committees and listening sessions that can improve upon programs like Medicare Advantage and Medicare and Medicaid.
So thank you for that. Allison, let me bring you back in. You've heard a lot of good comments here. What are the 2 or 3 things you think MA plans should do?
Yeah, so I don't want to sound like a broken record, but I'm going to say LTSS. I mean, I think that the biggest financial risk facing our healthcare system right now is the fact that long-term services and supports are not covered formally outside of the Medicaid program. And so we restrict them to the lowest income individuals in our nation. And often we bias toward institutional settings. So I think from a Medicare Advantage perspective, it's really starting to test innovative models, whether they be clinical, things like the capable model. They're dipping their toe in supplemental benefits in the non-medical space, maybe go a little bit further. But I think really kind of underscoring, Dennis, what you said is our policymakers need to have more provocative conversations about, like, do we federalize LTSS? Wow, that's a really provocative, big conversation. Do we bring LTSS in some capacity into the Medicare program? But I do think that Medicare Advantage plans have a role, a really strong role, given the flexibility that they have with their models and their benefits, to start to kind of inch in that direction.
Great. Well, let me summarize. Let me just thank the panel. Thank you for your perspectives and your services across the country to your organizations and the population, the betterment of our healthcare system. Allison, thank you so much for sharing your insights and data and getting this conversation started for us this morning. And in closing, let me just thank the Better Medicare Alliance for inviting us all to be here today and for the opportunity to engage in this really important conversation. And with that, I will wish you a good morning and thank our panel again.
Thank you.